Hello and welcome to another Pype pod. Today we're going to look at electrical axis deviation. Now I completely understand that this is an area that most people try to avoid. There are that have a general understanding. They describe the thumbs up, thumbs down methods, not really understanding what they're looking at with the heart or why we use certain values or what planes means versus leads. So hopefully today I'll illuminate the dark science of axis deviation and explain why certain things happen in the heart and why we look at an ECG a certain way in order to determine the area of travel. So the first thing to look at when we move into axis deviation is we have to go right back to anatomy physiology. Okay, anatomy physiology is very important, and the reason you're taught it early in your career, and you should be taught it very well, is because everything thereafter can relate back to the anatomy physiology that you learned. So if we look all the way back at the cardiac myocytes, so the cardiac cells themselves, you may remember that they have unique characteristics that is not found in any other muscle cells. So that is obviously their automaticity. That means that they can contract without the need for a neural impulse. Now the main ones that we look at when we're looking at axis deviation is their excitability and their conductility. Now what that means is they have the ability to generate an action potential, and with that ability they also have the unique structures to pass on that action potential to all the surrounding cardiac cells. So if one cardiac myocyte goes off, like a ripple effect, it passes that action potential through the intercalated discs in order to activate, if you will, the surrounding myocardial sites. From there, that excitability and conductility obviously relates to contractility within the heart, and it is this electrical activity happening all around the heart that we look at when we're looking at ECGs, and it's the relationship between them that gives us what's known as the mean axis, which we'll look at further. So taking those into account, we'll have a look at the ECG specifically, and we'll look at the terms leads versus planes. Now the word lead can be very confusing when we're dealing with ECGs, because sometimes it means the physical wire that's attached to the patient. But correctly, a lead or a lead system is an electrical picture of a heart's surface. A lead has a positive and a negative component. Now each one of the leads looks at a specific area of the heart from the point of view of the positive end of the electrode. And any impulse that travels towards the positive electrode are going to be shown on the ECG as a positive deflection. And any impulse that travels away from it is going to be shown as a negative deflection. Okay, so every single one of these leads has a point of view sitting, if you will, on the positive end and looking. And if it sees the impulse coming towards it, it's going to have a positive deflection. If it sees the impulse going away from it, then it's going to have a negative deflection. Okay, so AVR is a classic example for negative deflection. Okay, the electrical impulse is going away from the positive pole. Now, from there, we can look at something known as planes as well. So a plane is a way to divide the heart. So our standard 12-lead ECG utilizes 10 electrodes, okay, one for each of the limbs and 6 electrodes for the chest wall. Now the system is categorized into 3 lead systems. So you get your standard lead limbs, your augmented leads, and your pericardial leads. Now most monitoring systems will utilize these 3 leads. The initial 6 leads are obviously 1, 2, 3, AVR, AVL, and AVF. And these are termed limb leads because they derive from the electrodes that are attached to the arms and legs. Makes sense. The other 6 obviously look at the forces of depolarization for what's known as the horizontal planes. So your pericardial leads look at the horizontal planes, and your limb leads look at what's known as the frontal plane. Okay, and that's what we're going to focus on when we look at axis deviation. It is just the frontal plane. Now the frontal plane is a way of changing a 3-dimensional object, which is your heart, and looking at it in 2-dimensional view. So your frontal, which is your anterior chest wall. So imagine that you're looking at the frontal plane as just looking at the person's chest wall. And when we look at a horizontal plane, the pericardial leads, we're looking at like a cross section of the chest wall. So when we look at the leads specific to the frontal plane, we have lead 1. Now lead 1 connects to the right arm, which is a negative pole, and it goes towards the left arm, which is a positive pole. And lead 2 connects to the right arm, which is negative, as you can see, and travels towards the left leg, which is positive. And lead 3 connects to the left arm, which is negative pole, and then it travels towards the legs, which is a positive pole. Okay, so if you keep that in mind, that traveling down towards the legs is always positive, and only when the right side travels towards the left is that positive. Okay, all the other ones start on a negative plane and travel towards the legs. Now if we look a little bit further and have a look at the AVR, AVL and AVF, we can get a better understanding of what aspect of the heart we're looking at. So generally speaking, leads 1, 2 and AVL view the left side, left lateral surface of the heart. Lead 3 and AVF view the inferior surface of the heart, and AVR is there to view the right atrium. Now looking at the leads specifically, their direction of travel is towards the heart. So AVR connects from the right arm, the positive, and it travels towards the heart, which is a negative. So in all these cases, the heart represents the actual negative aspect of the leads themselves. AVL connects to the left arm and travels towards the heart, and then AVF connects from the left leg all the way up to the heart. Okay, so the left leg is the positive aspect, and when we're looking at these particular leads, they always start in a positive aspect and travel towards the heart, which is its negative aspect. So now knowing that, how do we get our axis? How do we know what the axis is, and what does the axis actually mean? So if we take what we've learnt so far, looking at the electrical activity of the heart itself, looking at the way the heart contracts, knowing that the heart has a general direction of travel, that's why we have SA, AV, Purkinje fibers, so it has a general direction of travel, but we also know that individual areas are going to contract and they're going to influence their surrounding areas. And the heart, when it contracts in more of a twisting motion. So the ventricles are more of a twisting, squeezing sort of contraction, as opposed to a simple linear contraction back and forth. So because of that, what we get is we have a huge amount of areas surrounding the heart that are going through depolarization and repolarizations. Now each one of these small areas are producing a large amount of small electrical currents. Now when we take all those electrical currents and we look at their direction of travel, we get what's known as a vector. And in this case, we're talking about an instantaneous vector. Now these vectors, if we get them and we average them out, we are obviously going to get a means vector. Okay, so the average of all the vectors is what's going to be known as means vector, and the direction in which most of the vectors are traveling is going to determine the overall direction when we look at the means. Now, the term vector is just a mathematical term that represents a direction, but also strength. Now, when we talk about strength in the heart, we're looking at amplitude. Okay, so it is the direction of most of the amplitude that gives us our mean vector. Now, to make it a little bit more obvious, because I understand it can be quite confusing, when we talk about access, we look at the QRS means. Now, obviously the QRF represents the ventricle activity. So if we look at the ventricles themselves, we all know that there's differences between the right and the left ventricle. So minutely, but still importantly, the completion of the right ventricle is actually going to occur first, because the right ventricle impulses have to travel through a thinner wall compared to the left ventricle. So the left ventricle depolarization and electrical activity is going to take longer because it has more tissue to actually get through. And because of that, most of the vectors that we'll find in the heart that make up the instantaneous vectors are going to lead towards the left-hand side. So when we look at a normal axis, the means QRS axis is going to start with the SA node and head down towards the left. So that's where we get this means axis from, and that's why we know what represents a normal axis. Okay, from there we need to determine what we actually do in order to calculate the axis or know when something goes wrong. And this is where the different methods of axis deviation comes in. So because we're dealing with amplitude and direction of travel, we've already mentioned that there's bipolar sort of lead travel, so towards a positive and a negative end. Now each one of those polarizations can be represented in a 360 degree fashion, okay, where we have positive degrees versus negative degrees. Obviously the negative degrees is going to sit at the end where most of the negative poles are. So if you remember back to the triangle, and we'll look at it again, they were the top half of the circle was the negative side, the bottom half was the positive side. So when we look at axis deviation, there's two main methods that you can use in order to calculate it. There's the Hex-axial method, which is very complex, takes a long time, and you need the picture in front of you in order to be able to do it. So I'm literally just going to mention quickly how to do that one, and then we're going to focus the rest of the lesson on the more rapid method. Okay, so the Hex-axial method is supposedly easy, but it's where most people get confused, but it is a very accurate way of determining the axis deviation. So the first thing we have to do is we have to find one of the leads 1, 2, 3, AVL, AVR, or AVF, with the smallest equiphasic QRF. Now what that means is it has an equal number of positive and negative amplitude. Okay, so if you look at the small boxes in the positive amplitude, you'll count 4 up, and the negatives will also be 4, so therefore it's the most equal, if you will. Now quite often you can just tell this by looking at it, but then sometimes you need to count those particular leads. So it's just a matter of counting the positive deflections and then minusing the negative deflection, and the one that is 0 is the lead you look at. From there, you turn the hexagonal diagram in front of you 90 degrees, and you look at the lead that is perpendicular, so the one that's sitting at 90 degrees to the lead that you found. And then you focus on that lead, and you determine whether or not that lead is predominantly positive using the same method, counting positive squares up, taking away negative squared. So is it more positive or is it more negative? And then from there you'll know which degree it is sitting at on your actual diagram itself. Now, to give an example, and then I promise we'll stop talking about it because this is the more complex method. If you have a look at the picture in front of you, and we determine, let's say, AVL is the most equiphasic QRS complex. Okay, so then if we go 90 degrees from that particular AVL line, you'll have lead 2. If you focus on lead 2 and you determine that lead 2 is mostly negative, then the axis deviation will be sitting at the negative 120 degrees. Okay. If it is mostly positive, then the axis deviation will be sitting at positive 60. Okay, now normal axis deviation is generally from 0 to positive 90, which we'll talk about in a little bit. Now sometimes negative 30 does get included in there, and then you get the actual degrees of the deviation from there. Okay, as you can see, quite a difficult, complex method, and you really need the diagram in front of you. The other method is the quadrant method. Now this is a easy, very rapid method, and you can do as part of your normal 12 lead ECG that you do. So that one is the one that we're going to look at, because in reality, if you notice anything outside of the norm, it requires further investigation. So looking at the position of the means QRS, okay, and the reason why we choose two particular leads. So if we imagine the exact same diagram that we've looked at, the one that is broken up into 30-degree segments all around the heart, the center of that particular diagram is designed to sit at the AV node. Okay, now the normal position we've already talked about, where that comes from with our means QRS vector. So the normal is to move down towards the left. Now the quadrant that represents that area, as mentioned, is 0 to positive 90. And that is the direction of a normal means QRS axis. Now the best leads to look at in order to ascertain that vector is lead 1 and AVF. So just breaking that down a little bit further so then we can understand, if we are determining an axis and we only get to look at one lead, okay, so if we look at just lead 1, okay, and if lead 1 is positive, then what that means is the axis is somewhere between negative 90 and positive 90. Okay, so it is somewhere between that entire half of the circle. Just by looking at the one lead, we have QRS positive, it is plus 90 to negative 90. If it's a negative deflection, it obviously means that it's from plus 90 to negative 90 the other way. Okay, so that's why lead 1 is often used when you're looking at axis deviation. So if you remember, lead 1 starts on the right and then goes towards the left hand side, and from the left hand side's point of view, which is a positive, the direction of the travel across the atrium, across the heart, is traveling from a negative side towards a positive side, therefore it should be a positive inflection. So that's lead 1. If we take a look at our other lead, which is our AVF, if we have a positive inflection on just AVF, that means that the direction of the vector is somewhere between 0 and positive 180. Okay, so if you only get to look at one lead, that's what it means. Now the position for AVF is starting at the feet and going up towards the heart. So from the perspective of the foot, which is the positive end, the direction of normal travel is traveling towards the feet. On an angle, it's still traveling down the heart. So therefore, we should have a positive inflection. If it's traveling away from the perspective of the feet, it is going to be a negative inflection. Okay, so that's what both of those particular leads mean. Now, the reason we use those two leads is because from those two leads alone, we can determine the relationship. Okay, so the relationship between V1 and AVF, if we break it down, lead 1 is looking at a complete horizontal plane right across the front of the heart from the anterior perspective. And AVF is looking at a vertical plane, the bottom of the heart all the way up from the anterior perspective. So you are getting a true cross section. And by looking at the relationship between them, you can build this quadrant. So if we look at normal, we've already talked about if it's positive, lead 1, you're going to be somewhere on the, looking at the screen, the right hand side of the circle, because it's positive in lead 1. And if it's positive in AVF, you're going to be looking at the bottom half of the circle. And the way we determine the which quadrant we're in is where do those two circles overlap. And in this particular case, it overlaps between 0 and 90 degrees. Therefore, it is giving us a normal axis. Always start, when you're looking at a 12 lead ECG, always start looking at lead 1. If lead 1 is positive, you will know you are going to have a normal or left axis deviation, because it's on the right hand side, the way you're looking at it, right hand side of the circle. Negative 90 to positive 90. That's what positive lead 1 means. Then if you look at AVF and you have a negative inflection, we have an area of the heart that is both right hand side by your perspective and top half of the circle. Where they overlap is in the negative 90 to 0, which is known as left axis deviation. Now in the event that you look at your ECG and you have a negative lead 1, okay, that means that you are going to have a right axis deviation or extreme axis deviation. So right there alone, you know that this needs further investigation. Just by looking at lead 1, you know that there's a problem. Now, depending on whether or not the AVF is positive, mostly positive inflection or mostly negative inflection, will determine whether it is right axis deviation. Okay, positive inflection is where it should be, so it's right axis deviation. If it's negative inflection, then you are dealing with the heart traveling in the exact wrong direction, which is known as extreme axis deviation. Okay, so those two leads alone is how we determine the quadrant method of axis deviation. As you can see, we don't get the breakdown of the 30 degrees, so we don't know the direction of the deviation, but we know that there's a potential problem that needs further investigation. And that, a lot of the time, is enough, because from there you can go get a better ECG in a better facility and then have investigations done from there. Now the reason we should do it and the reason we should know it, okay, because left and right axis deviation actually means something. Okay, it's not just a, oh yeah, look, your heart's traveling a slightly different way. Okay, it's generally because of some form of pathophysiological structures or changes in biochemistry that causes these deviations to occur. When you think about it, the normal direction of the heart is designed perfectly in order to optimize cardiac output. If that vector is on a different angle and a different means angle, it means the heart is generally contracting in a subpar way. Okay, and that can be the result of quite serious conditions. When we look at extreme axis deviation, we're generally dealing with good cases of emphysema, hyperkalemia, ventricular tachycardia, and then it also can be just because of an artificial pacemaker or putting the leads the wrong way, okay, but it can be quite a serious condition. And the left and right side of the house, as you can see, can be a myriad of problems in varying degrees of acute versus chronic problems. So our role is we need to determine it early in order to encourage further investigation. Now, just as a interest, the left axis deviation, there's a lot of arguments whether or not left ventricular hypertrophy is the cause of left axis. Now, most papers says that it's not a cause of left axis deviation, but it causes a lot of the other problems, or complements a lot of the other problems that do cause left axis deviation. Okay, as opposed to right ventricular hypertrophy, which is a cause to right axis deviation. Now we've gone through an overview of how it works. and why we look at it and where we get the numbers from, let's do a little bit of practice, and then we'll go through an explanation of how we actually got that. So if you have a look at the ECG in front of you, focus on the leads that we're supposed to, and come up with your answer. If you need more time, pause the video now before we move on to the answers and explanation. Okay, so the ECG that we were looking at had a positive inflection on lead 1 and a negative inflection on lead 2. Now that is going to lead us into the realms of possible left axis deviation. The way we got that, the lead 1 represents the positive side, negative 90 to positive, the right hand side of the circle, and a negative inflection of AVF obviously represents the top half of the circle, which gives us an overlap in the quadrant between 0 and negative 90, which is left axis deviation. If you look at another one, now I apologise for this particular one, I couldn't find one that was just the leads themselves, but I'm sure you'll still be able to break it down. This is what you'll generally get with a 12 lead ECG. Now remember, we're just looking at axis deviation, so try to ignore the other blatant problems in front of you. Okay, time for some answers. So the ECG showed us a negative deflection in lead 1. Okay, so we know that there's a problem. And then we had a positive deflection in AVF. Okay, so that means that we're going to be sitting in the quadrant on the left hand side with lead 1 and the quadrant on the bottom, giving us an overlap in the axis between positive 90 and negative 180, which is right axis deviation. Okay, so remember, as I said, if you have a negative in lead 1, then you are definitely going to have a problem. How big that problem is, whether it's right or extreme, determines on the positive or negative deflection of AVF itself. Okay. Moving on to the last example. Again, just look at the axis deviation, not the other glaring problems. Okay, now we're going for mostly negative or positive deflection, and we'll get the answers. Now this one here, hopefully you picked up straight away, has a negative deflection in lead 1 and AVF. Okay, so that puts us in the left hand quadrant and the upper quadrant, giving us an overlap in negative 90 to 180, which is extreme axis deviation. Now that ends the particular lesson. Hopefully you got something out of it, and hopefully it cleared up a little bit of mystery towards axis deviation. Until next time, take care.